Okay, good afternoon, everyone. This is Dr. Suhaila Al-Bannai, Senior Consultant, Prosthodontic and Dental Implant, Hamad Medical Corporation from Qatar. So the subject today is, the title is Preventive and Treatment of the Tooth Whitening Complications. Introduction. Tooth whitening is not a new technique in dentistry, as it is evident from the published literature that the technique was used for over 150 years. Teeth whitening is a famous cosmetic dental treatment because it can enhance the smile by making the teeth several shades whiter. But like other dental services, teeth whitening also comes with risk. Changing the color of the teeth is an evidence that involves a serious abundance of the patient's body. Despite the great experience accumulated in this area, no one can guarantee a certain result. This happens only because of the differences in the conditions of conducting, but also mostly due to the reaction of the human body to certain influences. The question concerning the whiteness of the teeth is a complex one, since tooth whitens will vary from individual to individual and is also dependent on the age of the individual and culture. Tooth whitening following treatment may also be dependent on the type of whitening system used to whiten the teeth. It is evident that individuals have different responses to tooth whitening. Some may respond very well to the process and have dramatically whiter teeth as a result, whereas others may notice very little differences at all. There are several side effects to the process, and these include tooth sensitivity, gingival irritation. For example, some individuals may experience no pain or sensitivity at all following the procedure. However, according to several investigators, many individuals will experience some kind of sensitivity either during and or after the initial treatment. This is usually described by patients as a sporadic, sharp shooting pain coming from their teeth following the procedure. Normally, these side effects should resolve after approximately 48 hours, although in extreme situations, this may last for several months. Overuse or misuse of teeth whitening procedure can also lead to enamel damage, gum irritation, and discoloration. Definition of tooth whitening. Tooth whitening is defined as any process that lightens the tooth color of the tooth. Whitening may be accomplished by physical removal of the stain or a chemical reaction to lighten the tooth color. Natural color of teeth. Teeth may made of many colors with natural gradation from the darker gingival third to the lighter incisal third. This variation is affected by the thickness and translucency of enamel and dentine, as well as by the reflectance of different color. Canine teeth are naturally darker than central and lateral incisors, and teeth become darker with age, whereas lighter teeth are common in younger people, especially in primary dentition. The color of teeth is primarily determined by the dentine, but is also influenced by color, translucency, and varying degree of calcification of enamel, as well as its thickness, which is notably greatest at the occlusal or incisal edges. The normal color of teeth is determined by the blue, green, and pink tints of enamel, and is reinforced by the yellow throughout to brown shades of the dentine beneath. The appearance of teeth depends on their absorptive or reflective properties of light, and is influenced by all structures that make up the tooth, including the enamel, dentine, and pulp. Any changes to this structure during formation or throughout development and post-eruption, 3 months in uterus to 20 years, can cause a damage in the light transmission properties and hence discoloration. Classification of tooth discoloration. We have intrinsic discoloration and extrinsic discoloration. Intrinsic discoloration occurs following a change to the structural composition or thickness of the dental hard tissue. This classification can be further divided into following categories: metabolic cause, inherent cause, iatrogenic, traumatic, idiopathic, and aging causes. The route by which pigment may become intrinsic are developmental defect, acquired defect, which might be tooth wear and gingival recession, and it might be dental caries and restorative material. Extrinsic discoloration is outside the tooth substance and lies on the tooth structure or in acquired follicle. Extrinsic tooth discoloration has usually been classified according to its origin, whether metallic or non-metallic. Metallic extrinsic staining of the tooth may be associated with occupational exposure to metallic salts and with the number of medicine containing metal salts. The non-metallic extrinsic stain are adsorbed onto the tooth surface, deposits such as plaque or acquired follicle. The possible etiological agent include dietary component, beverages, tobacco, mouth rinses, and other medications. Extrinsic discoloration can be divided into two categories: a direct extrinsic tooth staining or indirect extrinsic tooth staining. Direct extrinsic tooth staining, direct staining chromogen derived from dietary sources such as tea and coffee are taken up to their pellicle, and their natural color imparts the stain into the tooth surface. Smoking or chewing tobacco, medicines, and vegetables are also known to cause direct staining. Indirect extrinsic tooth staining, those which lead to staining caused by chemical interaction at the tooth surface associated with polyvinyl metal salt and cationic antiseptics such as chlorhexidine chloride and other mouth rinses. History of tooth whitening. From reviewing the published literature, it is evident that attempts to find an effective bleaching method have been made throughout the history of dentistry. The desire to have whiter teeth dates back at least 2,000 years ago. During the 1st century, Roman physicians claimed that the use of urine, especially Portuguese urine, when brushing the teeth would whiten the teeth. Barber surgeons also use a solution of nitric acid to lighten the teeth after using a coarse metal file to abrade the enamel. This technique was practiced until the late 18th century. According to some literatures, the bleaching of discolored pulpless teeth was first described in 1864, and a variety of medicaments such as chloride, sodium hypochlorite, sodium carbonate, and hydrogen peroxide were used, alone or in combination with and without heat activation. Further, in 1895, it was reported that the combination use of polizone 25% and electricity was effective in bleaching endodontically treated teeth. And in 1916, it was reported that the use of hydrochloric acid was effective in treating endemic fluorosis. In 1939, the use of 30% hydrogen peroxide, ether, and heat was advocated to treat fluorosis staining. And in 1966, the combination use of hydrochloric acid and hydrogen peroxide was promoted as a technique to remove brown stain from mottled teeth. In a study done in 1970, published a method for bleaching tetracycline stained teeth in a young adult with a history of cystic fibrosis. The so-called walking bleach technique was introduced in 1961 and involved the placement of a mixture of sodium perborate and water into the pulp chamber, which was subsequently sealed off between the patient's visit. The method was later modified and the water component was replaced by 30 to 35% hydrogen peroxide to improve the whitening effect. An observation by the orthodontist that application of 10% carbamide peroxide in a tray whitened teeth following treatment for gingivitis led to the concept of night guard bleaching. This observation subsequently led to night guard vital bleaching technique for a whitening teeth in 1989 when Haywood and Heyman described the use of 10% carbamide peroxide in a mouth guard for overnight use. The night guard vital bleaching technique for whitening teeth is still recommended as a take-home bleaching system for patient self-application. Currently, 4 different approaches to vital tooth whitening have been recommended and are as follows. The use of high concentration of hydrogen peroxide 35 to 50% or carbamide peroxide 35 to 40% dentist administered bleaching. Second, the use of a bleaching tray with high concentration of carbamide peroxide, which is 35 to 40%, which is placed in patient's mouth for 30 minutes to 2 hours and office dentist supervised bleaching. Third, at-home or night guard bleaching, which is patient administered in a form of custom-made tray with a solution of carbamide peroxide 5 to 22%, dentist provided bleaching, patient administered. And the fourth is various concentration of hydrogen peroxide or carbamide peroxide products available in a prefabricated trays or whitening strips to be used by patient consumers, over-the-counter product available for administration by patients and consumers. Tooth whitening system. Tooth whitening with different concentration of peroxide has been demonstrated to be safe and effective in a variety of regimens, including in-office procedure, dentist prescribed and supervised home treatment, and over-the-counter system approach. First, take-home system. Second, in-office system. 3, combination technique. 4, whitening strips. 5, light activated whitening system. 6, toothpaste. 7, over-the-counter product. Tooth whitening system. First, take-home system. The most common regimen is at home use of 2 to 4 weeks based on the color of the teeth at the start of the whitening. The use of hydrogen peroxide for removing intrinsic stains from vital teeth has been used for many years. Haywood and Heyman in 1989 published the first article describing night guard vital bleaching, and a tray was fabricated from the model of teeth using a soft plastic night guard. Take-home system. This tray was then loaded with carbamide peroxide gel and seated over the teeth for approximately 2 hours. The most commonly prescribed concentration are 10 to 22% carbamide peroxide. The advantages of the take-home system is the decreased cost compared to the in-office bleaching options. The major disadvantages are they require significantly patient compliance with the number of applications, usually involving 1 to 2 hours twice a day or overnight wear, and the entire treatment usually at least 4 weeks. In-office system. The most acceptable applications, they use 15, 30 or 35% hydrogen peroxide bleaching agent, heated or non-heated. The advantages of the in-office procedure are it requires minimum patient compliance and immediate results are attainable. The disadvantages are chair side time requirement cost to the patient, and usually require multiple office visits. Third, combination technique. By combination, the two techniques, in-office and take-home, there is a reduction in the amount of time and the need for repeated office visits, as well as expense associated in-office bleaching as a standalone technique. It increases the overall success and patient satisfaction. This procedure involves the use of high concentration of hydrogen peroxide, about 35%, delivered chairside for 1 hour, followed by a take-home regimen for 5 days. This is often followed by an additional chairside application. Whitening strips. A new method involves using 5.3% hydrogen peroxide impregnated polyethylene strips for 30 minutes twice daily. This method is recommended for maintaining already whitened teeth. It also be a good option to patients who cannot afford the cost of other whitening treatment or who do not have the time to multiple dental visits for tray fabrication. Development of this flexible polyethylene whitening strips allow for consistent bleaching using shorter contact time. Studies demonstrated that the modest increase in peroxide concentration ranging from 0.4 to 10% on the flexible bleaching strips results in increased whitening effectiveness without adversely impacting on overall tolerability. The fifth system is light-activated whitening system. The introduction of light-activated devices such as plasma arc, light-emitting diode, argon laser, metal halide, and xenon halogen lights by dental manufacturers have helped create a public demand for the light-enhanced tooth whitening system. The efficiency of this whitening system, however, is controversial. Published study appear to be equivocal. For example, a study done in 2003 reported positive results, whereas a study done in the same year, 2003, reported negative findings. Such studies, therefore, would either support a study done in 2002 or would refuse the efficiency of this system done in 2008. The use of hydrogen peroxide for bleaching teeth has also been supplemented with the use of heat. Tooth whitening system. To gain treatment time, clinicians have attempted to accelerate the degradation of hydrogen peroxide by using heat or light. First study done by Cohen and Parkins in 1970 introduced a technique for bleaching discolored teeth using hydrogen peroxide and handheld heating source. An in vitro study has demonstrated that the use of intense lights does elevate the temperature of the bleaching material and as a result may cause an increase in intrapulpal temperature. This observation may therefore have an impact on post-bleaching tooth sensitivity and pulp health. Light-activated chairside bleaching system, however, probably offer the benefit of being less time-consuming while producing faster results. The sixth tooth whitening system is toothpaste. Various types of toothpaste are available in the market as tooth whitening product, but only a small number of them show stain removal ability and effectiveness. Whitening toothpaste contain mild abrasives to remove surface stain. The peroxide content in the toothpaste are very low, 1% or less, and the exposure of these toothpaste on the tooth surface is minimum. Hence, there would be a minimum whitening effect. Over-the-counter product. Easy availability of the over-counter whitening product has been made the whitening of teeth more popular amongst people of all ages. There are different types of over-the-counter product like whitening dentifrices, tray-based whitening strips, and the recently introduced brush applicant. The latest inclusion to the over-the-counter product is a brush technique. This technique is non-tray-based paint on application. The over-the-counter bleaching kit requires the customers to use either a prefabricated tray or fabricate their own semi-molded tray, then fill it with supplied bleaching agent. These types are less than ideal because the trays are not custom fitted. Development of night guard vital bleaching. A successful home bleaching technique using hydrogen peroxide was first described in 1968 when it was noticed that the teeth became whiter after treatment of a mouth injury with glycoside, hydrogen peroxide mouthwash, and an orthodontic retainer. The results were lighter teeth in addition to the healing of the injury. This technique received worldwide acceptance when described by Haywood and Heyman in 1989, which employed 10% carbamide peroxide in a custom-made tray worn at night, the night guard vital bleaching technique. Development of power bleaching. In surgery, a bleaching technique used since the early 1900s were further modified in 1991 with introduction of 30% hydrogen peroxide gel activated by conventional light curing units rather than a heat source. This technique is often referred to as a power bleaching. Although these power gels could be controlled easily compared with the liquid used previously, full mouth isolation was still needed to protect the gum and surrounding soft tissue. Power bleaching was frequently combined with home use tray systems to maximize the bleaching effect and give a start to the whitening procedure before the patient continue with night guard vital bleaching at home. Current bleaching material. A further modification to the power bleaching system was the use of an argon laser as an activating light source to replace conventional curing light. The present-day system are activated by a variety of light source, plasma arc lamp, xenon halogen, light-emitting diode, light and diode laser. Light sources are not essential, and there are systems that require chemical activation only and are merely painted into the teeth with the usual use of gingival and mucosal isolation. Safety concern with tooth bleaching material. A variety of peroxide compound, including carbon dioxide, hydrogen peroxide, sodium perborate, and calcium peroxide, have been used as an active ingredients for bleaching material. However, all extracoronal bleaching material currently available for whitening of tooth of vital teeth contain carbamide peroxide and or hydrogen peroxide. Most out-the-counter bleaching products are hydrogen peroxide based, although some contain carbamide peroxide. An office bleaching material contain high hydrogen peroxide concentration, typically 25 to 38%, while the hydrogen peroxide content in at-home bleaching product usually ranges from 3 to 7.5%. However, there have been home use products containing up to 15% hydrogen peroxide. Chloride dioxide is not safe to be used as a tooth whitening treatment due to the low pH of the material and the resultant toothache. Carbamide peroxide decomposes to release hydrogen peroxide in an aqueous media. 10% carbamide peroxide yield roughly 3.5 hydrogen peroxide. Because of the potential of hydrogen peroxide to interact with the DNA, concerns with carcinogenicity and co-carcinogenicity of hydrogen peroxide have been raised, although these concerns so far have not sustained through research. However, studies have shown that hydrogen peroxide is an irritant and also cytotoxic. It is known that at concentration of 10% hydrogen peroxide or higher, the chemical is potentially corrosive to mucous membrane of skin, causing a burning sensation and tissue damage. During office bleaching treatment, which routinely uses material of greater than or equal to 25% hydrogen peroxide, severe mucosal damage can occur if gingival protection is inadequate. Clinical studies have observed a higher prevalence of gingival index in patients giving bleaching material higher peroxide concentration. Regarding hard tissue, transient, mild to moderate tooth sensitivity can occur in up to 2/3 of users during early stage of a bleaching treatment. Sensitivity is generally related to the peroxide concentration of the material, and the contact time. It is most likely the result of the easy passage of the peroxide through intact enamel and dentine to the pulp during 5 to 15 minutes exposure interval. However, there have been no reported long-term adverse pulpal sequelae where proper techniques are employed. The incidence and severity of tooth sensitivity may depend on the quality of the bleaching material, the technique used, the individual's responses to bleaching treatment methods, and material. To date, there are little published evidence documenting adverse effect of dentist monitor at-home whiteners on enamel, but 2 clinical cases of significant enamel damage have been reported, apparently associated with the use of out-the-counter whitening product. This damage may be related to the low pH of the product and/or overuse. In March 2005, the European Scientific Committee on Consumers Product concluded that the following: the proper use of tooth whitening product containing less than 0.5 to 6% hydrogen peroxide or equivalent for hydrogen peroxide releasing substances is considered safe. Then it was subsequently updated in 2007. The safety of tooth bleaching for children and adolescents is also a consideration. More research is needed to establish appropriate use and limitation for these patients. However, bleaching is a conservative approach compared with the restorative options when the tooth discoloration causes significant concern. It is, if possible, delaying treatment until after permanent teeth have erupted is recommended, as it use of a custom fabricated bleaching tray to limit the amount of bleaching gel. Close professional and parental guardian supervision are needed to maximize benefit and minimize adverse effect and overdose. Customized bleaching tray should be used to limit the amount of bleaching gel. Adverse effect following tooth whitening procedure. According to a study done in 2002, the most common adverse or side effect of using custom-made bleaching tray, 10% carbamide or 30 to 38% hydrogen peroxide, is transient tooth sensitivity. Gingival irritation may also occur if the tray is improperly made. The so-called internal bleaching or walking in office technique using 35% hydrogen peroxide when treating endodontically treated teeth has been reported to cause root resorption. Cervical root resorption. A review of published case reports on cervical root resorption revealed 22 such cases following intracranial bleaching. 58 bleached, which equals to 30% hydrogen peroxide and heating, pulpless teeth were followed for 1 to 8 years, and 4 cases, which is 7% of external root resorption, were observed. a high concentration of hydrogen peroxide in combination with heating seemed to promote cervical root resorption, in line with observation made in animal experiments. Tooth sensitivity. Tooth sensitivity is a common side effect of external tooth bleaching. Data from various studies of 10% carbamide peroxide indicated that from 10 to 65% of the patient reported increased tooth sensitivity. Higher incidence of tooth sensitivity from 67 to 78% was reported after in-office bleaching with hydrogen peroxide in combination with heat. Tooth sensitivity normally persists for up to 4 days after the cessation of the bleaching treatment, but a longer duration up to 39 days have also been reported. Patients with a previous history of tooth sensitivity may thus have a higher risk for such an adverse effect from external tooth bleaching, and this should be taken into account before treatment begins. Mucosal irritation. A high concentration of hydrogen peroxide from 30 to 35% is a caustic to mucous membrane and may cause burn and bleaching of the gingiva. In a clinical trial that used 10% carbamide peroxide in a custom-made tray, from 25 to 40% of the patient reported gingival irritation during treatment. During the active treatment phase of their study, participated using the experimental 7% hydrogen peroxide bleaching solution reported significantly more tooth sensitivity, gingival irritation, and days of each compared with the control group. Tooth sensitivity and gingival irritation, as reported by the participant, was mild to moderate. After ending the treatment, teeth sensitivity, gingival irritation was resolved in 2 to 3 days and did not recur during the 10 months post-treatment. The results of this study indicate that the hydrogen peroxide bleaching solution evaluated can be safely used to treat teeth. Alteration of tooth surface. Morphological alteration of tooth following tooth bleaching has been addressed in several studies. Significant surface alteration in enamel topography were observed in enamel slabs treated with the bleaching solution for 4 weeks. Incidence of bleaching sensitivity during and following tooth treatment. Haywood et al. 2001 reported an incidence of tooth sensitivity of 53% using 10% carbamide peroxide in a custom-fitted tray. Haywood 1999 has also reported an overall general sensitivity rates to whitening of 75% of the patient. Browning et al. 2004 reported that 67% of patients experienced transient sensitivity during bleaching. Transient tooth sensitivity in the presence of hydrogen peroxide or carbamide peroxide is related to both dose and time. The higher the dose or concentration of the whitening agent and the longer the time are expected, the greater the risk of tooth sensitivity. If such sensitivity occurs, the easiest way to address the problem is to decrease the treatment time or the dosage of hydrogen peroxide or carbamide peroxide. For whitening agents delivered with a tray, it is critical to trim the tray accurately, not only to ensure that it is accurately reflects the position of the gingiva, but also to position the tray border at the cement enamel junction. Although pain in the bleached teeth can be evoked by thermal or other stimuli, most patients complain of tingling or shooting pain zinger without provoking stimuli. This pain may continue for a period of following the actual bleaching treatment. Teeth defects such as caries, defective restoration, or exposed dentine have been suspected of being more prone to bleaching sensitivity than intact teeth. These defects may provide a direct diffusion pathway for peroxide to deep dentine. Patients with sensitive teeth prior to bleaching are described as being considered particularly prone to bleaching sensitivity. It has been suggested that there may be some degree of pulpal inflammation associated with the bleaching sensitivity. The bleaching sensitivity during tooth whitening literature review. Several investigators have advocated the use of desensitizing product when considering bleaching or whitening teeth. For example, the use of a product containing 5% potassium nitrate or fluoride in a tray prior to, during, and following treatment may be beneficial in reducing bleaching sensitivity. Amorphous calcium phosphate can also be used either as toothpaste or as a professionally applied product. For patients with a pre-existing dentine sensitivity, the use of a desensitizing product prior to bleaching the teeth may alleviate further discomfort during the bleaching phase of the treatment. The efficacy of this desensitizing agent used in a patient who experienced tooth sensitivity during tooth whitening has been reported in a study of such patients who had a pre-existing symptoms prior to the start of whitening procedure. According to Haywood 2000 and Tridin et al. 2006, sensitivity is a common adverse reaction of external bleaching and may persist up to 4 days following bleaching, although a duration of up to 39 days have been reported. Reported incidence of dentine sensitivity ranges from 15 to 65% with the patient using 10% carbamide peroxide, whereas higher incidence, 67 to 78%, were reported when using hydrogen peroxide in a combination with heat. Risk factors for the development of a bleaching sensitivity and gingival irritation that are associated with night guard vital bleaching were reported. No statistical relationship exists between age, gender, or tooth characteristic with the dental arch bleached and the development of side effects. However, there was statistically significant association existing between the side effects and the whitening solution used. This association, however, disappeared when the analysis was controlled by usage pattern. Patients who changed the whitening solution more than once a day reported more statistically significant side effects than did those who did not change the whitening solution during their usage time. Precaution of tooth whitening. During tooth whitening procedure, manufacturer instructions should be followed carefully. Teeth whitening treatment should never be done more than once daily. Contact with gum and lips should be avoided. Patients should stop immediately and consult their dentist if they experience any sensitivity or discomfort during treatment. Teeth whitening is generally not recommended for pregnant or breastfeeding, have cracked teeth or gum disease, children under 16 years of age, patient with periodontal disease, patient with color decay, cavities, exposed roots, people who are allergic to tooth whitening agent like peroxide, and individuals with sensitive teeth. That's why patients are advised to consult their dentist before starting any whitening procedure. Professional tooth whitening performed in a dentist's office is recommended once every year to every 18 months, depending on how much the result lasts. At home, kits can be used as often as once every 4 to 6 months. Whitening teeth too often could cause certain oral health concerns, such as worn down enamel. Custom-fitted tray and in-office treatment are the safest and most effective way to whiten teeth. ADA-approved over-the-counter toothpaste, gels, and strips are more affordable and convenient option. Following whitening teeth, avoid the following for at least first 48 hours after treatment. drinking a strongly colored beverage, eating foods that stain, colored dental hygiene product, tea and coffee, and cut out tobacco product. According to the dentist, any drink with color, especially things like coffee and soda, can negatively impact teeth whitening after treatment, which is why we do not recommend drinking any substance with coloring for 48 hours after whitening treatment. After whitening, patients are also advised to avoid acidic food and drinks. Acidic food and drinks such as soda and citrus fruit can irritate the mouth, increasing the sensitivity that one can experience. Continue using a desensitizing toothpaste, brushing with desensitizing toothpaste, and or applying a desensitizing gel for the first 48 hours after the whitening procedure will help the patient to cope with any sensitivity that may experience. Brush gently. The use of soft bristle toothbrush and to rinse with warm water help to minimize sensitivity. To drink through a straw. Drinking through a straw right after a whitening treatment will help to prevent the liquid from contacting the teeth, which can minimize discomfort. If the patient are absolutely must drink an ice cold beverage, they can sip it through the straw to avoid contact with the teeth. To use fluoride product, toothpaste and mouth washes containing fluoride can help remineralize the teeth and block the pain signals to the oral nerves. Patients are advised to avoid any food or beverage that are extreme in temperature for at least a couple of days after teeth whitening treatment. This includes cold foods like ice cream, as well as hot drinks and beverage like coffee, tea, and soup. The bleaching agent in teeth whitening solutions open the pores of the teeth and leaves the nerves that reside inside the teeth vulnerable, which is why sensitivity is common. However, if the teeth are not exposed to food and beverage that are irritating, heightened sensitivity should be much of an issue. To help to prevent some of that sensitivity, patient can ask the dentist to use a teeth whitening product with a lower concentration of hydrogen peroxide for an in-office treatment. The lower the hydrogen peroxide concentration, the longer the patients need to use the product, but they will likely experience less sensitivity because of it. It's also recommended that the patient speak to dentist if they are experiencing a recurring sensitivity. Most importantly, the patient should always avoid over-the-counter whitening product. These systems use generic trays which don't fit the contour of the mouth probably, causing the bleaching gel to contact the gum. This will increase the sensitivity the patient experiences for treatment. If the patient has sensitivity before start whitening, it is recommended to use a desensitizing toothpaste 2 weeks prior to the at-home whitening treatment, as well as to continue use during and after whitening treatment. Consult the dentist about using desensitizing toothpaste to help to relieve sensitivity after whitening. Using a soft bristle toothbrush, brushing with toothbrush with firmer bristle, especially if the patient brushing too vigorously, can lead to further damage to the gum and to the enamel. Brushing the teeth is one of the most important aspects of the good oral hygiene routine, so patients should continue to brush regularly after teeth whitening treatment. Brushing will further open the pores to the teeth, which can make tooth sensitivity worse. As a precaution, patients should brush their teeth right before teeth whitening treatment and then not again for several hours after treatment is complete. Patients should continue using a toothpaste designed for sensitivity in the week after treatment. This type of toothpaste can protect tooth enamel and minimize or eliminate discomfort related to the tooth whitening. Internal bleaching with 30% hydrogen peroxide solution is aesthetically very successful in the short term. However, in the long term, the success rate falls to 50%. This procedure is associated with the risk of external root resorption, documented both clinically and experimentally. To prevent tooth sensitivity after tooth whitening, patients should start preparing prior to treatment. It is a good idea to take an over-the-counter pain medication about 30 minutes before the treatment begins. This can prevent discomfort and sensitivity before it even starts. If irritation develops after pain medications has worn off, it can be used again as direct until sensitivity subsides. The best medications to choose are those that are anti-inflammatory, such as ibuprofen. Summary and conclusion. Tooth whitening has become one of the most requested dental treatments by the public. Tooth stains are classified according to their origin into two categories, intrinsic and extrinsic. The whitening systems are generally organized into two classes, in office and at-home products. Most of the whitening systems use hydrogen peroxide as the active oxidative agent to degrade the organic compound that cause stain. Modern tooth whitening procedure include treatments with carbamide peroxide and hydrogen peroxide gel of different concentration, with or without the application of light from various sources. Carbamide peroxide breaks down into hydrogen peroxide and urea, with the hydrogen peroxide concentration being approximately 1/3 of the original carbamide peroxide percentage. According to current scientific data, the time required to achieve the greatest whitening effect depends directly on the treatment duration and the concentration of applied gel, but does not depend on the gel type. Various concentration of tooth whitening gel can be used during whitening procedure, with or without the use of different light source. Light is the catalyst that increases the absorption of the gel and accelerate the chemical oxidation process. Tooth whitening procedures may adversely affect both hard and soft tissues in the oral cavity, as well as dental pulp. Although, when these procedures are performed as per manufacturer instructions, these effects generally are mild and transient in nature. Whitening solution with greater than 10% carbamide peroxide appeared to cause more tooth sensitivity in the study participants. Studies using night guard vital bleaching with 10% carbamide peroxide reported two main side effects, namely tooth sensitivity and gingival irritation. Although tooth sensitivity was more prevalent than gingival irritation, however, both of these side effects were transient in nature and disappeared at the end of the treatment. For whitening, two major approaches can be distinguished as follows: chemical bleaching by peroxide and mechanical bleaching by toothpaste abrasives. Chemical bleaching leads to good results, especially when it is performed with high peroxide concentration in a controlled environment, that is the dental practice. Mechanical cleaning relies on suitable abrasives that are harder than stain but less hard than enamel. Considerably progress into this direction has been achieved with silica toothpaste formulated in the last years. Using fluoride toothpaste significantly reduces tooth sensitivity. For internal whitening in teeth previously treated with endodontically treated, studies reported 1% enhance of cervical resorption, especially in case of whitening with thermocatalytic technique. This procedure is significantly reduced by the application of calcium hydrogen mixed with the distilled water in a paste form to the office of teeth that have undergone internal tooth whitening treatment. The thermocatalytic technique is a procedure that is no longer recommended in terms of the evolution of internal bleaching technique. Moderate to great sensitivity to tooth whitening procedure and dental clinic condition is known to occur post-treatment, as hydrogen peroxide has the ability to pass easily through the enamel and dentine but does not cause pulp damage. For this sensitivity, it is indicated to give light analgesic to the patient. The whitening procedure remains a procedure that is always sought by dentists who mainly evaluate the aesthetic changes without going into details on microscopic damage that occur on the tooth surface where the whitening is applied. Patients who had a pre-existing history of tooth sensitivity or with recession and associated with tooth sensitivity may be more likely to experience sensitivity, tooth sensitivity during the bleaching procedure. The main concern when it comes to whitening teeth is that some products may contain a harsh chemical that can weaken or damage enamel over time. The most common ingredients in these products are hydrogen peroxide or carbamide peroxide, which can be abrasives when used in high concentration. Patients who have a pre-existing history of tooth sensitivity or with recession and associated tooth sensitivity may be more likely to experience tooth sensitivity during the bleaching procedure. The available data from the published literature would suggest that extra coronal bleaching treatment in the dental office or at home may cause short-term tooth sensitivity and or gingival irritation. More severe mucosal damage is also possible with high concentration of hydrogen peroxide. While available evidence supports the safety of using bleaching material of 10% carbamide peroxide, which equals to 3.5% hydrogen peroxide by dental professionals, there are concerns with the use of at-home bleaching material with high hydrogen peroxide concentration. Studies designed especially to assess the long-term safety of high hydrogen peroxide concentration in at-home bleaching material are needed, especially for repeated use of these products. It appears to be insufficient evidence to support the unsupervised use of peroxide-based bleaching material. Thank you.